Hello and welcome to the Coding Corner, Medical Coding Education. Today we will be covering Chapter 1 of the ICD-10-CM Chapter-Specific Coding Guidelines. My name is Kristen Robinson. I am a coder, auditor, and educator, and this is Session 1 of 22 that we will be covering for the chapter-specific coding guidelines. So be sure to hit that bell and follow the page to be notified for future episodes. Chapter 1, Certain Infections and Parasitic Diseases. When we talk about Chapter 1, this includes A00 through B99, U07.1, and U09.9. The human immunodeficiency virus, HIV, infectious agents as causes of diseases classified to other chapters, infections resistant to antibiotics, sepsis, severe sepsis, and septic shock infections resistant to antibiotics, methicillin-resistant Staphylococcus aureus or MRSA conditions, the Zika virus, and the coronavirus infections. When we talk about HIV infections, there are many guidelines that we must follow. So, HIV or human immunodeficiency virus infections. Code only confirmed cases. This is an exception to the Hospital Inpatient Guideline, Section 2H. In this context, confirmation does not require documentation of positive serology or culture for HIV. Simply the provider diagnosing the patient with HIV is sufficient for us to code HIV. Selection and sequencing of HIV codes. If the term AIDS or HIV disease is documented, that is enough to bill code B20. When a patient is admitted for an HIV-related condition, B20 should be the primary or principal listed diagnosis, followed by additional diagnosis codes that report the HIV-related conditions. There is one exception to this rule, and that's for hemolytic uremic syndrome associated with HIV disease. In this case, you're going to use D5931 for infection-associated hemolytic uremic syndrome, followed by B20 for HIV. A patient that is admitted for an unrelated condition to the HIV, the unrelated condition, for example, a traumatic injury, should be coded as the principal diagnosis with B20 reported as a secondary code. When patients are newly diagnosed with HIV, the sequencing is irrelevant. For asymptomatic HIV positive or HIV test positive, you'll use Z21 for asymptomatic HIV infection status to assign. When there is inconclusive HIV serology, we want to make sure we use R75 for inconclusive laboratory evidence of HIV. When a patient is previously diagnosed with an HIV-related illness and we start coding B20, that patient should no longer ever be assigned R75 for inconclusive laboratory evidence in HIV or Z21 for asymptomatic HIV infection status. When this changes is when we involve the pregnancy, childbirth, and puerperium. Chapter 15 always takes sequencing priority. Therefore, in a patient during pregnancy, childbirth, or the puerperium with documented HIV disease, a code from O98.7 should be coded with B20 as a secondary code. If a patient presents during pregnancy, childbirth, or the puerperium with documented asymptomatic HIV infection, you will still code O98.7, but then you will code Z21 instead of B20. When you have an encounter for HIV testing, this is without signs or symptoms, use code Z11.4, and then you can use additional codes for any associated high-risk behavior if applicable. When a patient presents with signs and symptoms of HIV, then you will use the code Z71.7 for the counseling provided for the encounter of that test. Code Z11.4 is for the screening that should not be assigned if there are signs or symptoms present. If the test result ends up being negative, Z71.7 for the HIV counseling should be assigned. When there is an HIV disease or HIV positive status managed by an antiretroviral medication, B20 should still be coded, and if the patient is diagnosed as asymptomatic HIV status and on antiretroviral medicine, then you would use Z21. So make sure you know the difference on whether or not they have an active HIV or HIV-related condition or AIDS. You'll use the B20. If it is asymptomatic on antiretroviral medicine, you're going to use the Z21. You can also code an additional code Z79-899 for other long-term current drug therapy for the use of the antiviral medications. Now, when it comes to prophylaxis measures, the code Z29.81 should be used for pre-exposure prophylaxis or PrEP. When we start talking about infectious agents as a cause of diseases classified to other chapters, we now start into our B codes. Okay, so we're going to be covering B95, B96, and B97 in this section. A code from B95, Streptococcus, Staphylococcus, or Enterococcus as diseases classified to other chapters. B96 is other bacterial agents as the cause of diseases classified to other chapters, or B97, which is for viral agents as the disease classified to other chapters. This is to be used as an additional code to identify the organism. And remember, there will be an instructional note found at the infection code advising you to use that additional organism code. When we have infections resistant to antibiotics, there is a code Z16 for resistance to antimicrobial drugs following the infection code if the infection code does not identify the drug resistance. With sepsis, severe sepsis, and septic shock, infections that are resistant to antibiotics also have specific coding guidelines. When we are coding sepsis and severe sepsis, if the organism is not further specified, we need to make sure that we assign code A41.9 for sepsis unspecified organism. A code from subcategory R65.2 for severe sepsis should not be assigned unless severe sepsis or an associated acute organ dysfunction is documented. When we see negative or inconclusive blood cultures in sepsis, it does not preclude a diagnosis of sepsis in patients with clinical evidence of the condition. But if this does happen, please make sure that you query your provider. If documented as urosepsis, this is considered a nonspecific term, and it is not synonymous with sepsis and has no default code in the alphabetic index. So if this is documented, please query your provider for additional clarification. When we have sepsis and organ dysfunction, sometimes called multiple organ dysfunction or MOD, MOD, follow the instructions for coding severe sepsis. When we have acute organ dysfunction that is not clearly associated with sepsis, the sepsis and the acute organ dysfunction must be documented in the medical record in order to bill the code R65.2. An acute organ dysfunction must be associated with the sepsis in order to assign this severe sepsis code. If the documentation is not clear as to whether an acute organ dysfunction is related to the sepsis, again, make sure you query your provider. With severe sepsis, we have two codes at a minimum. First, code the underlying systemic infection, followed by a code from subcategory R65.2. If the causal organism is not documented, assign A41.9, sepsis unspecified organism for the infection. You can also code additional codes for the associated organ dysfunction as required. When we talk about septic shock, this normally refers to circulatory failure associated with severe sepsis and therefore represents a type of organ dysfunction. Now, for cases with septic shock, we want to always code our systemic infection first, followed by the R6521 for the severe sepsis with septic shock, or for post-procedural septic shock, T81.12. You can also code any of the additional acute organ dysfunctions as appropriate. And I will remind you on a couple occasions, but remember septic shock, your subcategory R65.2 codes cannot be coded as principal diagnoses. When we are sequencing severe sepsis, there are also rules that must be followed. Remember, the underlying systemic infection should be assigned as the principal diagnosis, followed by the R65.2 code as the secondary diagnosis. When we have severe sepsis with a localized infection, we have to also follow the same guideline. The systemic infection should also be coded. So, if the reason for the admission is sepsis or severe sepsis and a localized infection such as pneumonia or cellulitis, code the underlying systemic infection should be assigned first, then code the localized infection as the secondary diagnosis. When we have severe sepsis, you can also code from R65.2 as appropriate as a secondary code. When we have sepsis due to a post-procedural infection, the code assignment is based on the provider's documentation of the relationship of the infection and the procedure. So when we're talking about sepsis due to a post-procedural infection, we have examples such as a post-procedural wound or surgical site. So this is going to be from codes T8141 through T8143 or T8149 following infection following a procedure at a surgical site. Remember, when we have an obstetric patient or an obstetric wound, we also need to make sure we're following our Chapter 15 guideline where we code the O code as the primary code. And in this case, it would be O86.00 through O86.03 or O86.09. You can also assign an additional code for the sepsis following the procedure, including T81.44 and O86.04. If the patient has severe sepsis, you can code the R65.2 as an additional diagnosis. For infections following a infusion, transfusion, therapeutic injection, or immunization, code from subcategory T80.2 or T88.0. If the patient also has severe sepsis, you can also code R65.2 as an additional diagnosis. When we talk about post-procedural infection and post-procedural septic shock, there are also codes that need to be assigned. When we have this is when an infection has resulted in a post-procedural septic shock, you want to assign the codes indicated above for sepsis due to the post-procedural infection, followed by T81.12 for the post-procedural septic shock. Something very specific here, we do not want to assign a code from R6521 as a secondary diagnosis. But you do want to make sure that you add the additional code for any organ dysfunction. When we have sepsis and severe sepsis associated with a non-infectious process, we also have a guideline that we must follow. In some cases, a non-infectious process or condition, such as trauma, can lead to infection that results in sepsis or severe sepsis. If sepsis or severe sepsis is documented as associated with a non-infectious condition, such as a burn or serious injury, and this condition meets the definition for principal diagnosis, the code for the non-infectious condition should be sequenced first, followed by the code for the resulting infection. If severe sepsis is present, a code from category R65.2 should also be assigned with any associated organ dysfunction. Remember, it is not necessary to use from subcategory R65.1 for systemic inflammatory response syndrome or SIRS. If the definition is met for principal diagnosis, it should be sequenced before the non-infectious condition. Remember, when both the associated non-infectious condition and infection meet the definition of principal diagnosis, either may be assigned as the principal diagnosis. Also remember, only one code from R65 signs and symptoms specifically associated with the systemic inflammation and infection should be assigned. When we have sepsis and septic shock complicating abortion, pregnancy, and childbirth, and the puerperium, see section 1C15 for additional information. For newborn sepsis, see section 1C16.F for bacterial sepsis of a newborn. And last for this slide, hemolytic uremic syndrome associated with sepsis. As we referenced earlier in the presentation, make sure that you assign D59.3.1 as the primary or principal diagnosis, and then the underlying systemic infection and any other conditions can be assigned as secondary diagnoses. Moving on to MRSA, methicillin-resistant Staphylococcus aureus conditions. So we also have several guidelines that must be followed in this particular section. Number 1, selection and sequencing of MRSA codes. Sometimes there are combination codes for the MRSA infection as well as the condition. And in those cases, you would not use an additional code for B9562 when the code includes the MRSA. For example, sepsis due to MRSA code J15212, pneumonia due to MRSA do not code the B5962. Also, do not assign a code from subcategory Z16.11 for resistance to penicillins as an additional diagnosis. When we talk about other codes for MRSA infection, there are some times that they do not include the MRSA infection in the code itself. For example, wound infection, stitch abscess, or urinary tract infection do not include MRSA as part of a combination code. And in these cases, B9562 would be appropriate as a secondary diagnosis. Again, do not code from Z16.11 resistance to penicillins in this case. When we have MSSA or methicillin susceptible Staphylococcus aureus and MRSA colonization, there is also a guideline that we must follow. Colonization that MSSA or MRSA is present on or in the body without necessarily causing illness. When there is a positive MRSA colonization test, it may be documented as a MRSA screen positive or MRSA nasal swab positive. You can assign code Z22322 for a carrier or suspected carrier of MRSA. You can assign code Z22321 for a carrier or suspected carrier of methicillin susceptible Staphylococcus aureus. For patients documented as having MSSA colonization, but does not necessarily mean that there is a disease process happening within that patient's body. When we have MRSA colonization and infection, if they are documented as having both MRSA colonization and the infection during that hospital admission, code Z22322, which is your carrier or suspected carrier of MRSA, and a code from the MRSA infection may be assigned. With the Zika virus infections, we also have a couple guidelines that must be followed. Number one, we need to make sure that we code only confirmed cases. If there is a confirmed case of the Zika virus, you will use A92.5 as documented by the provider. Again, this is an exception to the hospital inpatient guideline section 2H. And again, as stated previously, confirmation does not require the type of test performed. The provider's diagnostic statement that the condition is confirmed is sufficient. This code can be assigned regardless of the stated mode of transportation. But suspected, possible, or probable Zika do not code A92.5, code the signs and symptoms, or Z20.821 for contact with and suspected exposure to the Zika virus. Now, when it comes to coronavirus, there are a ton of different things that need to be followed. Now, our primary code for COVID-19 is U07.1. And again, code only confirmed cases. And again, this is an exception to the inpatient guideline previously mentioned and the confirmation previously mentioned. Also, suspected, possible, and probable also follow this guideline. And if you need additional information on coding signs and symptoms, see guideline 1C, 1G, 1G. When we are sequencing codes for COVID-19, the principal diagnosis of U07.1 should be sequenced prior to any associated manifestations for this code. Remember that there are certain chapters, such as the obstetrics chapter, sepsis, or transplant complications, that may have rules that overtake this particular sequencing. For acute respiratory manifestations of COVID-19, you will code U07.1 for COVID-19 as the principal first listed diagnosis, followed by the respiratory manifestation. So we have a few examples here: pneumonia you're going to use U07.1 followed by J12.82. When we have acute bronchitis, U07.1 and J20.8. For bronchitis not otherwise specified, use U07.1 and J40. For lower respiratory infections not otherwise specified, U07.1 and J22 should be assigned. When documented as an other specified respiratory disorder, use U07.1 and J98.8. Now, with ARDS, or acute respiratory distress syndrome, you're going to use U07.1 and J80 for the acute respiratory distress syndrome. And lastly, acute respiratory failure. You'll use U07.1 and a code from J96.0 and the appropriate additional characters as appropriate. We have several other guidelines that we're going to breeze through for this particular screen. Non-respiratory infections, again, U07.1 followed by whatever that manifestation code is. When there is exposure to COVID-19, Z20.822 would be the appropriate code choice. As far as contact and exposure goes, if you want to review this more in depth, reference 1C 21C1 for contact and exposure and the use of Z20 codes. When we are screening for COVID, use Z11.52. If there are signs and symptoms without a definitive COVID-19 diagnosis, make sure you use the appropriate signs and symptoms such as acute cough, shortness of breath, or fever. If there is contact with or suspected exposure, Z20.822 would be appropriate. If a patient is asymptomatic and they test positive and there is no provider documentation of a diagnosis, please query your provider. We also have a personal history of COVID-19, and you would use Z86.16 for this. If a patient has a follow-up from COVID and it has now resolved, you will use Z09 for the encounter for follow-up examination after completed treatment for conditions other than a malignant neoplasm, and Z8616 for the personal history of COVID. If you want additional information on this, see the guideline 1C, 1G, 1M. There's also section 1C21.C.8 for factors influencing health states and contact with health services follow-up. If there is an encounter for antibody testing that is not being performed to confirm current COVID infection, use Z01.84. And you can apply the guidelines for the individual being tested to confirm a current COVID-19 infection. When we have multi-system inflammatory syndrome, or MIS, you want to assign a code U07.1 as the first listed diagnosis, followed by M35.81 for the MIS is an additional diagnosis. Now, if a person has a history of COVID and then develops the MIS, you'll want to make sure that you code the M35.81 and the U09.9 for post-COVID condition. When a person has a known or suspected exposure to COVID with no current COVID infection or history of COVID infection, you want to use M3581 and Z20.822. If there is post-COVID sequela, associated signs or symptoms that develop after the COVID infection ends, you're going to use U09.9. And just remember, code U09.9 should not be assigned for manifestations of an active or current infection. If a patient has a condition associated with previous COVID and then develops a new COVID infection, you want to assign both U09.9 in conjunction with U07.1. And lastly, for this chapter, under immunization of COVID status. If you have someone that is completely unvaccinated for COVID-19, assign code Z28.310, and if they are partially vaccinated, use code Z28.311. If you need additional guidance on this, see section IB 14 for under immunization documentation by clinicians other than patient's provider. Now, that does conclude Chapter 1 coverage for the ICD-10-CM guidelines. My only reference is the guidelines, and I look forward to seeing you at the next session.